Good afternoon and welcome to this briefing for the House Health Committee. I'm Delegate Heather Bagnall, Chair of the committee, joined by our amazing Vice Chair, Delegate Bonnie Cullison. This is our 2 o'clock briefing, but we are running a little late, so if you see that it's 3 o'clock, you are not incorrect, but this is our 2 o'clock briefing. So I ask for your patience if we encounter any technical or streaming issues. This briefing is being live streamed on the Maryland General Assembly YouTube channel. Panelists will control the transition of their slides. Now, before this briefing, all members were emailed a copy of each presentation. If you do not have these documents, please let committee staff know and we will send you a copy. Please be advised, if you are in the gallery, we ask that there be no food or drinks. You will see our members staying hydrated throughout these long meetings. I do ask that our members, once again, adhere to the regular rules of our committee. 1 question, 1 answer, not 1 answer per panelist. We are also joined in this briefing and the next briefing by the Health and Human Services Subcommittee of the Health Appropriations Committee. So welcome to all of you for being here. Today, the House Health Committee will hear from the Certified Community Behavioral Health Clinics, and we'll begin with Ms. Nicole Grainer. If you want to come up, introduce yourself, and introduce your panel, and we can get started.
Good afternoon, Chair Bagnall, Chair Bagnall, Vice Chair Cullison, and members of the Health Committees and HSS Subcommittee of Appropriations. For the record, my name is Nicole Grainer, and I am the Director of Government Affairs and Public Policy with the Community Behavioral Health Association of Maryland. Thank you so much for the opportunity to be here today. Before I get into my slides, though, I want to be clear about why I'm here. The General Assembly has supported CCBHCs for years because they are designed to address the problems you keep running into: hospital overstays, access gaps, emergency departments being used as the default front door for behavioral health services, and kids and adults cycling through crisis and inpatient settings when community care isn't available soon enough. You've continued to support the CCBHC model through legislation and budget decisions because it directly addresses those challenges. Today's conversation is about whether Maryland protects the progress it has already made or risks sliding backward at a moment when the need for reliable community-based care has never been greater. CBH is the statewide trade association representing Maryland's community-based behavioral health providers. Our 95 members deliver mental health and substance use services across the full continuum of care, serving adults, children, families, and seniors in urban, suburban, and rural communities across the state. Importantly for today's discussion, CBH represents all 5 of Maryland's current Certified Community Behavioral Health Clinic expansion grantees. These providers have been operating under the CCBHC model for nearly a decade, with the first CCBHC expansion grants beginning in 2018. These are not pilots on paper. They are functioning clinics in Maryland right now, delivering care, meeting federal requirements, and producing measurable outcomes. I'm not here today to convince you that behavioral health needs your attention. You already know that. What I want to do is make sure that we're all talking about the same model and the same decision points. So today I'll start with the CCBHC model and how it's designed to address the system challenges you've been grappling with for years. Then I'll talk about some of the outcomes we're seeing both nationally and right here in Maryland, when the model is implemented as intended. I'll walk through what's at risk if Maryland slows down now, and I'll close with what's needed to protect the investment you've already made and keep this work moving forward. Certified Community Behavioral Health Clinics are a federally defined clinic model designed to meet the comprehensive behavioral health needs for children and adults. And that federal definition matters because it establishes enforceable requirements around access, services, care coordination, and accountability. This slide shows the required activities and service array under the CCBHC model. The intent of the model is simple. People should not have to navigate multiple systems, wait lists, or referrals just to get basic behavioral health care. As CCBHC expansion grantees, Maryland's CCBHCs are required to attest to SAMHSA that they offer outpatient care, 24/7 crisis services, care coordination, substance use treatment, and supports for children and adults under one accountable structure, either by providing those services themselves or through a formal agreement with a designated collaborating organization, or DCO. This one-stop approach is what helps reduce unnecessary hospitalizations, emergency department use, and hospital overstays. CCBHCs function as a reliable front door to behavioral health care. Same-day access reduces emergency department utilization by engaging people earlier, before conditions escalate to crisis. Required crisis services prevent unnecessary inpatient admissions and pediatric overstays. Care coordination improves discharge planning and continuity so people don't fall through the cracks after a hospitalization. And whole person care reduces repeat crises and justice system involvement by stabilizing individuals in their communities. And we have evidence that this works. Nationally, CCBHCs now operate in 46 states, covering nearly 60% of the United States population, with strong bipartisan support at the federal level. Maryland CCBHC expansion grantees serve 6,400 individuals in FY25. This is not a new or experimental model. It is the direction that behavioral health policy is headed. In New York, which has implemented the CCBHC model at scale, the state saw a 61% decrease in clients using hospital inpatient services and a 54% reduction in all-cause hospitalization readmissions. Those are system-level outcomes tied directly to earlier access, stronger crisis response, and coordinated transitions out of inpatient care. And we see the same pattern in Maryland. Maryland's CCBHC grantees perform significantly better than the national average on 7-day follow-up after hospitalization. In Montgomery County, cornerstone CCBHC implementation has resulted in 83% fewer emergency department visits, and inpatient utilization has gone down 35%. On the Eastern Shore, Healthport CCBHC has expanded assertive community treatment and reduced hospital length of stays by 40%. And in Baltimore and Prince George's counties, Volunteers of America has expanded access to services by offering extended weekend and evening hours. These outcomes are important because they show exactly what is at risk if CCBHC capacity erodes. The CCBHC demonstration is the mechanism that allows Maryland to move from grant-funded participation to a sustainable model. The CCBHC demonstration allows Maryland to operationalize CCBHCs over time. It creates predictable, accountable funding through the prospective payment system, which reimburses providers based on the actual cost of providing care. The same principle that is long used for FQHCs and managed care organizations. It brings an enhanced federal match, which is currently 65%. And it allows the state to control timing, scale, and participation. The demonstration does not require immediate statewide expansion. It does not force uniform implementation across all communities, and it does not replace all other funding or eliminate the need for phased growth. Proposed BRFA language would change Maryland's obligation to apply for the demonstration from shall to may, and delay the demonstration application from FY26 to FY29, and tie action to future budget availability. This is not a technical adjustment. It materially alters Maryland's trajectory and will have significant consequences. 4 of the 5 current CCBHC expansion grants expire on September 30, 2026. Many of the CCBHC grantees have used grant funding to supplement services or implement services that are not Medicaid reimbursable, including on-demand medical translation in over 200 languages, providing nursing staff within the residential programs and outpatient mental health clinics, offer benefits counseling, and expanded care coordination and peer support services. Without a clear path forward, access gains are at risk of rollback, crisis capacity weakens, workforce investments become unsustainable, and pressure shifts back to emergency departments and inpatient units. In the 2025 Mental Health America rankings, Maryland ranked 40th nationally for youth mental health. That ranking reflects high levels of unmet need and lack of access to care for children and adolescents, reinforcing the urgency of strengthening early, community-based behavioral health services right here in Maryland. If Maryland continues to delay implementations of models specifically designed to fix access, crisis response, and continuity, those rankings will not improve. They will continue to get worse. Delay doesn't hold the system steady. It reinforces reliance on the most expensive, most strained parts of our system: emergency departments, inpatient beds, and prolonged hospital stays. Previous MDH implementation cost estimates were significantly higher than what we've seen in other CCBHC states. Based on conversations with national experts, those figures seem to rely on assumptions that don't reflect how CCBHCs are actually implemented, including how services are defined and how costs are shared between the state and federal government. Under the demonstration, Maryland would receive a 65% federal match, meaning the federal government covers the majority of costs. That enhanced FMAP is intended to lower the state's share when the model is structured appropriately. It is also important that cost discussions, represent the full scope of CCBHC services. CCBHCs are comprehensive community providers, not just outpatient mental health clinics, so limiting assumptions to a single service type doesn't accurately capture how the model functions or how system costs shift. And as we look at costs, it's important to ensure that the assumptions behind the numbers match the model. But that's not to say that your questions about costs aren't legitimate. These are significant investments and scrutiny is appropriate, including the costs associated with providing services regardless of insurance status or ability to pay. But behavioral health care is already being paid for in Maryland, including for those without insurance, and much of it is being paid for outside of the community. We pay through emergency departments. We pay through inpatient hospital beds. We pay through prolonged hospital stays and repeated cycles of crisis care. The CCBHC model does not eliminate cost. It shifts care earlier, stabilizes people sooner, and prevents the most expensive outcomes from becoming the default. And that structure is exactly what allows clinics to sustain same-day access, crisis capacity, and workforce stability. What is being asked for is not immediate statewide expansion. What is needed now is a clear commitment to move forward with the demonstration. $6 million in bridge funding to preserve existing CCBHC capacity and continued legislative oversight to ensure momentum is not lost. And so I will close where I began. The General Assembly has consistently supported CCBHCs because the model addresses problems you continue to confront: hospital overstays, gaps in access, emergency department overutilization, and fragmented transitions out of inpatient care. CCBHCs in Maryland are not theoretical. They are operating today. They are producing outcomes that align with national evidence. And the question before us is not whether the model works. The question is whether Maryland protects the progress and investment it has already made or continues to fall further behind other states. Thank you. Do we need to switch the slides? I don't know how to.
Do you need to switch places?
Good afternoon. While we switch the slides, I'll introduce myself. I'm Marshall Henson. I'm the Vice President and Chief Operating Officer of Shepherd Pratt. And I'm here to give you a little bit of an on-the-ground provider experience with CCBHCs. Thank you. So Shepherd Pratt is the nation's largest private nonprofit behavioral health provider, serving over 80,000 individuals annually across 400 sites in 16 Maryland jurisdictions. So we have that footprint in 16 jurisdictions. However, we support the full state with a full continuum of care that's accessible to all. Some of that continuum includes school-based mental health services, outpatient mental health services, substance use disorder treatment, crisis intervention and diversion services, as well as psychiatric hospital care, residential programs, and care coordination, especially for high acuity and high utilizer populations. What you see right now on this slide is a map of all of our services across the state of Maryland. So you can see our footprint, and it gives you a feel of our scale. We are in each of the jurisdictions providing support, providing critical behavioral health care. I want to talk to you a minute about our motivation for why we started with CCBHCs. What we see with CCBHCs is really this opportunity to align Shepherd Pratt's mission, but also behavioral health's goal to implement comprehensive community-based care. One of the important aspects of CCBHCs is what we have added onto with respect to outpatient mental health clinic services. And so when we look at outpatient mental health centers, what we know right now today is that structurally there's fundamental misalignment with the rate structure. Maryland's OMHC fee-for-service rates have not been updated in any meaningful way in over a decade. The current methodology reimburses short, episodic encounters rather than the intensive team-based model required for individuals with serious and persistent mental illness to stay healthy in communities. As a result, OMHCs do not cover the actual cost of delivering evidence-based care, also care coordination, nurse education, peer supports, and health behavior coaching, those key ingredients to keeping people successful in the community. CCBHCs were designed to fix this exact problem. CCBHC model is built around a prospective payment system that funds the entire care team needed for high acuity populations, those peers, those nurses, those care coordinators, clinicians, psychiatrists, and integrated SUD services. Maryland's demonstration grant allows us to build the model, but without that prospective payment system, we're forced to operate within a grant-funded mechanism that is not sustainable for Maryland. Maryland's current approach is half-built, so the current amount of dollars available on the demonstration grants to providers funds a handful of positions, but not enough to carry out the full intent of certified community behavioral health centers. Without a new rate methodology established within the Medicaid structure, we know that care coordination that is so vital to the success of people being well in communities will not be an important function within OMHCs or the function of CCBHCs larger. What we also know about the rate methodology for OMHCs, again, it is for billable encounters. It is not for that whole team approach. So those items that aren't covered under Medicaid services under OMHCs is all of that behind the scenes work. So if we think about managing medications, helping those high utilizers manage medications, that is not covered. Coordinating care with hospitals and emergency departments is not covered. Helping patients obtain benefits is not covered. Addressing transportation, insurance lapses, or other social determinants of health needs are not covered under OMHC structure. Also, this idea of presenting crises before they develop is not a covered service under OMHC. So under OMHC rates, the work is either unpaid or it's disincentivized. So you really are looking at those brief episodic encounters rather than whole health care for individuals. This is exactly why we chose to operate CCBHCs, to move from a visit-based system to more of a population-based system. Maryland has proof of concept this model works, but without that prospective payment system, that reimbursement model, we know that we cannot scale, right? We are working on grant-funded operations at this point. Our ability to scale means we need to be able to adjust with a payment system that is in place where we can serve the numbers of people that are seeking these services.
Wait, but it's not.
Got a technical difficulty on advancing the slides.
It's all right. We are flexible. That is our mantra. We are flexible.
That's okay. We'll keep going while we're getting the technical difficulties fixed. So I want to talk a little bit about what CCBHCs look like in practice. This model is built for people with serious and persistent mental illness. We're serving people with serious and persistent mental illness and complex social determinant of health needs. Over time, the CCBHC model changes that trajectory for individual clients as well as the broader high acuity population. Care coordination really is the differentiator here. That is what keeps people engaged in treatment and care over the long term. And it's that engagement in treatment and care that will drive costs lower over time. The other beautiful benefit of CCBHCs is we really bring closer parity to somatic care and behavioral health care. So we take basic vitals, we screen for somatic care needs, we educate clients on managing their chronic illnesses, we check medication interactions, and we make direct referrals to primary care. These are the kinds of interventions that stop crises before they escalate, before they arrive at our emergency departments, before they arrive at the front door of criminal justice. We work on the misconceptions that our high utilizer population has with the use of emergency departments. Emergency departments do not need to be the front door for behavioral health care, and yet that has become the default. So as we work with high utilizers in CCBHCs, we do a lot of that education of how you can access behavioral health care without having to access the emergency departments or inpatient psychiatric care. In order to do that, we need that care coordination. So after we provide therapeutic services, we can connect that person with a care coordinator. We can help them get connected to that primary care physician. We can schedule that appointment. We can make sure that they get seen. That saves an emergency department visit if they weren't connected to care and services. I want to talk a little bit now about who we serve and clinical focus areas. I won't read all of these to you, but you have them in front of you. So we serve over 2,400 individuals across our CCBHCs. What you see in terms of primary diagnoses are those mood disorders, schizophrenia, anxiety disorders. Co-occurring substance use disorders represent 20% of our population. And the number right below that is really important, and that's the Medicaid saturation rate. So over 78% of our population are Medicaid consumers. You can see the age groups that are there. There's a pretty even spread across the board, representing children, youth, and families, all the way to geriatric services. Our referral sources tend to be acute care hospitals, other caregivers, family members, clients who know our services, and we also have close partnerships with 988 and mobile crisis teams that are deployed throughout the state. We've got a slide on most frequent services delivered. What we tend to see primary services within CCBHCs is that outpatient therapy. It's also that psychiatric care, medication management, care coordination, crisis intervention, screening, and assessment. That top service is often that psychiatric rehabilitation group service as well as individual therapy. Again, it's that engagement factor that keeps people in treatment over time, that allows us an opportunity to see when there's problems, intervene, and prevent crises from escalating. When we think about outcomes within CCBHC, I want to be very clear on what we have seen at Sheppard Pratt. So number one, improved access to care, right? Same-day access is critical if we're going to divert people from emergency departments and even interactions with criminal justice. We know that we can implement immediate processes after crises to make sure that people stay in their communities healthy and well. I want to draw your attention to the next point, which is that reduced reliance on emergency departments as well as inpatient psychiatric care. What we have seen in our short time with CCBHCs is a 45% reduction in client use of ED care. So absent CCBHC services, 45% of those 2,400 clients that we talked about earlier would be accessing emergency department services with regularity. We've also seen improvements in physical health outcomes. For 55% of our client population with hypertension, we've seen reduced blood pressure levels to healthy levels. For 59% of clients with diabetes, we've seen that move to controllable levels and improved A1Cs. So very tangible, specific health outcomes related to CCBHCs. I wanted to provide a specific example of a typical client that comes into our care, the type of services that they receive, and the outcomes that we see when we provide that care. So we had a 38-year-old female diagnosed with schizoaffective disorder, bipolar disorder, and diabetes enroll in our CCBHC. This individual had uncontrolled diabetes, blurry vision, and cataracts. Multiple ED visits throughout the year and throughout the course of their time before connecting with us. And this individual was scheduled for cataract surgery, but was not able to participate in that surgery because of the uncontrolled diabetes and blood pressure issues. So the interventions that we provided through our CCBHC was that psychiatric assessment, that connection to a psychiatric provider. We provided referral and care coordination services between the physical health providers as well as the treatment team that Sheppard Pratt provided for behavioral health. We provided ongoing education for this individual around medication compliance, healthy diet, blood sugar monitoring, and we initiated an affordable prescription service for this individual. The results were that this individual was medically cleared for that successful eye surgery. There were no further ED visits after we engaged with this individual, and no inpatient psychiatric admissions. We established a primary care connection for ongoing care for all of those somatic needs. We established the pharmacy service that was needed, and we connected her to an endocrinologist. We're happy to report today, as a result of her being able to receive that surgery, receive this ongoing care, and that intense level of care coordination to keep her healthy in the community, she is actively engaged in employment at this time. So that is not an extreme case. That is an example of clients that walk through our door every day and the type of work that we can do to keep them healthy and well in the community, but also to drive down cost over time. So what have CCBHCs brought to patients? So we have really shifted to an integrated care model with a focus on those tangible health outcomes. We've improved access for traditionally expensive high utilizers. We've connected patients, their teams, their families to educational resources, again, to make sure that they are engaged and stay healthy and well in their communities over a lifetime. And we've adopted that population health mentality where we can really look at high utilizers within our system, be it high utilizers of emergency department care, inpatient psychiatric care, or justice-involved care. Some of the operational constraints that we've encountered. So we have a few structural barriers. This is a demonstration project at the provider level. So we're operating on about $1 million at the grant level. That provides us an opportunity to hire several special disciplines, hire some of those care coordinators. However, it doesn't allow us an opportunity to fulfill the full mandate of CCBHCs. We also don't have a Medicaid rate, and I've talked about that need for the PPS rate. We need that in order to build budgets, plan for the future, and really address this high acuity population, this high utilizer population over time. We also know that operating on this grant funding leads to staffing instability. We only have this grant funding committed to by 1 year at a time. That gives uncertainty to those members who join our team who know that that funding is in jeopardy. It also doesn't allow us to scale at the levels that we see people walking through our doors or seeking this level of care. So the reality is that operating under a federally defined model without drawing down those federal dollars is completely unsustainable. So we see our grants ending September 29th of this calendar year, 2026, which leaves CCBHC's operational future uncertain. So we have an opportunity to think about how we move forward with CCBHCs across the states. Many states now have proven that CCBHCs work. Nicole provided some of those examples. We know that there are system implications over time. We have all talked about the importance of parity within the behavioral health arena, ensuring that we integrate medical care within behavioral health care and ensure that that engagement and that integration happens over time. We also know that increases to federal support for outpatient care alleviate pressures for emergency departments and avoidable criminal justice interactions and lower lifetime costs. So the question is not about whether CCBHCs work. It's whether Maryland will take full advantage of the opportunity to invest in a sustainable system for outpatient care. So provided we don't continue in this arena, what we know at the end of the day, those things that will end are really those intense care coordination services, nursing services, peer services, the ability to serve people regardless of payer, benefits counseling, addressing barriers around social determinants of health, and we will further limit access, especially for those high utilizers that cost our system so much. I thank you for your time, and I'm happy to answer any questions.
Thank you very much. And for the sake of time for our members, I'm going to go to the next panel and continue on CCBHCs, but I ask if you can stay, and we'll take all questions at the end, because some of our questions may be answered with the next panel. Deputy Secretary Lord, welcome back.
Long time no see, y'all.
Deputy Secretary Briskin, welcome back. If you want to go ahead and start, and just for the record, since this is a separate stream.
So good afternoon. Good to see you all again. I have the honor and privilege of serving as the Deputy Secretary for the Behavioral Health Administration. My name is Alyssa Lord. I am joined by Deputy Secretary Perry Briskin, who is our Deputy Secretary for Healthcare Financing and the state's Medicaid Director. I am pleased to provide an update today to the House regarding efforts that are underway to support Maryland's Certified Community Behavioral Health Clinic Planning Grant. I am glad that you got a chance to hear from two of our partners, CBH and Sheppard Pratt, who are actively working with us on this critical work. So let me see if I can chew gum and walk at the same time. All right, so for some history and context, CCBHCs were established by Congress, my apologies, through PAMA about a decade ago. There are core provisions that must be executed for states to implement CCBHCs, including participating in the planning grant, setting the foundation through CCBHC certification standards, determining a prospective payment system, and a submission of a demonstration grant application. And what I will tell you is all of that work is currently underway now. Oh, my apologies, I'm jumping too far ahead. Not dissimilar, and I think you heard some of this in the presentations from Sheppard Pratt and CBH, there are a set of 9 core services that must be rendered. It is not dissimilar, for example, from federally qualified health centers who are meant to be designed as a single source of care regardless of ability to pay. And, you know, many of these services may look familiar, as these are services that are reimbursed currently through the public behavioral health system, including crisis services, outpatient mental health, and peer services. And these are all currently offered in Maryland through various initiatives and funding mechanisms. So from the national CCBHC landscape, as of 2024, there is a total of 199 certified. So you will hear this distinction between certified and non-certified. Those that are certified are eligible to be reimbursed through the prospective payment system. For the remainder of those throughout the country, they are receiving either SAMHSA expansion grantee funding, which is again something that you had heard from our existing CCBHC partners. They receive SAMHSA expansion grant funding or other funding mechanisms, but are not reimbursed through the PPS system. And there are approximately 500 CCBHC or CCBHC-like entities across 46 states, but 20 states have completed the demonstration grant application and are in process of either establishing or having already established CCBHCs. So from an evaluative perspective, we do see wide variability across states as it pertains to cost and quality. In the most recent Assistant Secretary for Planning and Evaluation analysis that came out of HHS, what they found is across 3 states who have really led the implementation of CCBHCs, so that's Nevada, Minnesota, and Oklahoma, we saw that in 2 states there was an increase in spending for CCBHC participants. 1 state saw an increase in access to services, and 2 states saw a decrease in psychiatric and emergency department use. But in 1 state, this only applied to a specific population, which is adults. So as you can see here, almost annually, HHS ASPE releases data and information, and this is something that the department reviews pretty regularly to help understand what are the ever-changing dynamics and what are we seeing in those states that have established CCBHCs to help inform our work. So in the Maryland landscape, and I think we've touched on this a little bit, right? So legislation was passed previously for Maryland to apply for the planning grant as well as for future demonstration grant participation. And so we were awarded the planning grant funds in December of 2024, and those dollars are being used to help support staffing as well as our stakeholder engagement work and contracting for specific services such as cost reporting and provider training, as well as extensive stakeholder and consumer engagement. And I will say, through this work, we do meet with our stakeholders at least on a monthly basis to continue to advance this work. I will say there was some delay in starting this work as a result of the BRFA language that was introduced last legislative session. But once that language was removed, we did expeditiously move forward with convening the stakeholders to start the planning grant activities. So, you know, what you see here is a representation of the 5 existing CCBHC grantees that have been awarded dollars from SAMHSA to continue to support this work. And so, you know, part of the SAMHSA expansion grantee work is to help get them ready to become CCBHCs or ensure that they are building the necessary infrastructure and service delivery model. I will say that based off of our assessment and through our conversations with our existing CCBHCs, none of the CCBHCs currently offer the full suite of all 9 core services within their single entity or through what are called designated collaborating organizations, where you bring together a constellation of providers to make sure that you are delivering on all 9 core services so that you know, if we were in a demonstration, you would need to be able to demonstrate all of those 9 core services so that you could receive payment through the PPS. And so, you know, this work continues to evolve with our partners as we are building out the certification requirements. Again, as I made that distinction earlier between a certified and a non-certified CCBHC, there are certification requirements that we as a state are working with our partners to develop. And those certification criteria include staffing, so making sure that they have staffing plans in place, the availability and accessibility of services, care coordination, which I know Shepherd Pratt talked extensively about, the scope of the services, which is reflective of those 9 services, and quality and other reporting as designed, including around quality measures, a plan for quality improvement, and tracking of other program requirements. So those are sort of state by state. We do look at other states and how they've developed their certification criteria so that we are not necessarily reinventing the wheel, but this is all part of the work that is happening within our current planning grant activities. This also allows time for our existing CCBHC expansion grantees, as they're a part of this process, to think about what are the pieces that they need to put into place should we be successful in a future demonstration grant application. And then here's just a sense of the timeline of when the planning grant was released, from when we were awarded funds to when we started the work, and the work that remains ongoing. So cost reporting is a big piece of this, which is how are we going to determine the PPS and what we are reimbursing, along with there is a JCR. Last legislative session, there was a JCR that was requested that is due May 1st, so we are eagerly working on that, which looks at the cost, quality, and effectiveness of CCBHCs nationally. And then we are actively working on developing those certification applications, which would go to the existing grantees, with hopefully being able to identify which of the CCBHCs meet those certification criteria at the end of this year. What you will notice is that we have applied and did receive a no-cost extension from our SAMHSA partners. This is not necessarily uncommon. There is a fair amount of work that goes into meeting all the planning grant requirements, and certainly not something that we want to rush to make sure that we are building a quality and effective model of care for the state of Maryland. And so, as you heard from some of our partners, we have proposed that we would apply for a future demonstration grant application. I will say that there is not a current demonstration grant application that has been posted. It has been forecasted on the SAMHSA grants dashboard, but I think we are all daily checking to see what is happening at the federal level. So at this time, there is no SAMHSA demonstration grant application that has been posted. But again, the department continues the due diligence to track what is happening at the national level. And this just gives you a sense of all of the ongoing work that is happening within. So what you'll see here is a subset of the required activities, what is the current status of those activities, and how does it align with the demonstration grant requirements. So as I stated before, the department is recommending that we move to apply for a future federal demonstration grant opportunity. Part of this is tied to wanting to make sure, as I said before, that we finalize all the existing planning grant activities. We want to make sure that we are continuing to lean into what we are learning from other states who have done this and have done it well. We know that there is a continuing budget resolution that expires January 30th. And so we are assessing what the federal impacts potentially could be for existing federally funded program, let alone what future federally funded programs could look like. And then the other caveat to this is that when Maryland was awarded our planning grant, we were one of 15 states. And for what SAMHSA has potentially forecasted is that only 10 demonstration grants would be awarded in the next cycle. So that's just another piece that we're taking into consideration. So a couple of other points that we wanted to underscore around possibly delaying implementation until 28-29 is the submission of a demonstration application for outer years. It will not disrupt service delivery. These services, as you heard, right, OMHCs and some of these other services are already being reimbursed through the public behavioral health system, or for our uninsured population, they are being paid for through state general funds. So if we do not submit a demonstration grant application when and if it is released in fiscal year 27, there will be no service disruption. Organizations will be able to continue to provide these services and continue to get reimbursed. The other piece of this is that, we understand that there are concerns about the potential sunsetting of the SAMHSA expansion grant funding. I spoke with SAMHSA last week, and similarly, they anticipate re-releasing expansion grantee funding, and the existing 5 Maryland grantees are eligible to reapply for SAMHSA expansion grantee funding, as well as if they have any unexpended funds from their current grant, they are able to apply for a no-cost extension. So in terms of projected costs, and these are cost estimates that have been updated relatively recently based on data and using what we call the PPS1. I know we use a lot of alphabet soup in healthcare, but that is the prospective payment system. That is a daily rate. And how Maryland modeled our proposed PPS rate, and I know there might be some confusion about this and layering on of other services and whatnot, but we took a look of the average of 4 existing PPS1 states, such as New York, and we modeled our rate off of those 4, and happy to provide you additional detail about which 4 that we used and the rates that we used to do this modeling. And so, what you see here is some early modeling that the department has done, where we anticipate for the cost for 2 sites, and just to underscore, 1 must be rural. For the demonstration grant application, you must have 1 rural site and then 1 non-rural site. But we anticipate the cost for 2 sites are about $13 million in total costs. And again, for CCBHCs, we also must be required to cover anybody regardless of their ability to pay. In terms of next steps, we are actively working on that JCR, and here it does give the breakdown of what we will be covering in the JCR, which is anticipated implementation costs and cost savings, potential payment for services, including the methodology that we used, a description of the impact on funding, service delivery, and the cost-benefit analysis and additional data collection needs and analytic needs that we will need in order to ensure Maryland's success. And then lastly, I think this is also, just from our perspective, an important point is that some of you may remember the HOPE Act of 2017. We certainly did not forget it, but transparently, we are just starting on the Behavioral Health Rate Setting Study Act. We think this is an important piece for how we think about reimbursing behavioral health services in the state of Maryland. Many states across the country undertake a rate setting study to understand how we are reimbursing, as well as how do we compare with other states nationally that are reimbursing for services. And so, we want to use this information to help further inform what we think the rate development should look like for the PPS. Again, as I said, we've taken a look at what other states are doing for their PPS1, but we also want to understand how do we load balance or rate balance some of the rates that we currently have in the state, especially if it requires a shifting of some of these costs. We have finite resources that we have to work within, right? So if there's some redistribution of assets or resources within the rate structure, then we need the rate setting study to help inform what does that look like by looking at cost per service. And so the other piece, as I mentioned before, is that we want to continue to look and learn from other states and what they're doing as it pertains to quality, cost, and outcomes. And with that, I am happy to take any questions.
I'm going to open it up to our counter partners in appropriations. And do you want, Ms. Grainer and Mr. Henson, do you want to go ahead and just come up so we can take all questions at once? Chair Shetty.
There we go. Thank you so much, Madam Chair. Just a quick shout out to the HSS members that have joined today, and those I know who have stepped out briefly but will be back. We've got Delegate Ruff, who is a big champion for CCBHCs and was super instrumental in getting the JCR language in last year. Delegate McCaskill, Delegate Heinbaugh, and I know Delegate Dana Jones stepped out but will be likely back soon. First is a super brief comment and then a question to Deputy Secretary Lord. I am so thrilled by this presentation in so many ways. I feel like we've come full circle on so many of these discussions, and I just want to point out how grateful I am to see such a commitment from the administration in really diving into the details around the value of CCBHCs. I know we had a lot of good conversations around these issues last session, around the BRFA in particular, and so I'm grateful that SAMHSA has given us 1 year further, no cost extension for the appropriate planning to be done, and to hear that the administration is committed to making these necessary investments going forward after that, even with the delay. One quick question to you, ma'am, is in one of the slides, you indicated that the delay would be either to FY '28 or '29. I just want to get some clarity again on sort of which year you're thinking and what will happen between now and then, because we only have that 1 year extension. So explain to me the timeline and what will happen. Thank you.
Sure. Thank you, Chair. Appreciate the question. Good to see you. So we are beholden to the federal cycle as to when demonstration grants are released. So the reason why it says 28, 29 is contingent upon when they release the application in that year. And also remember, we have a different fiscal year than the feds do. So they might release the application in federal fiscal year 28, but it wouldn't start for us until fiscal year 29 when we would receive the dollars to start the demonstration grant.
Okay, so then, okay, I understand. And so the second part of my question, ma'am, was related to what happens between now and then.
So we continue the planning grant activities. We have up until a year to do that. We will also be working on finalizing that JCR, and we will be doing the rate setting study over the next 12 to 18 months, which will again continue to inform. We also fully intend to continue to maintain the standing monthly, if not more than monthly, stakeholder engagement meetings that we are having to make sure that we continue to partner with our existing CCBHCs and supporting their efforts.
Thank you. Thank you, Madam Chair. Thank you. Delegate Ruff.
Thank you, Madam Chairs, and thank you to the panel. My chair and I evidently are sharing a frontal lobe today. It's possibly because we went to the greatest university on the planet. Go Duke. Come on, y'all. Get over it. Get over it, right?
I'll gently remind
let's
everyone
bring it
there's
back.
another briefing.
So,
I was about to say we might need to have Shepherd Pratt come and do some interventions here.
well, funny enough, I was able to go visit Shepherd Pratt's CCBHC this year in October, and not for that reason. But I was there to make observations of the work that they're doing, and I just want to say, obviously, what I saw was very encouraging and even has made me want to double down on, supporting these efforts for this partnership, which I'll echo my chair's comments about seeing the partnership in action, although I think that there are some disconnects, or at least based on the presentation I saw. So my first question was about timing, so thank you for clearing that up. And then the statement about there not being an interruption or potential for interruption of services, I'm wondering if, kind of from both sides of this partnership, if you can kind of give us a sense of, because what I think I hear Mr. Henson saying is that it's likely that services could be, interrupted. So can you guys kind of on both sides give us an understanding of your positions there and give us some guidance on how we can be supportive of making sure that there are no interruptions, because these services are absolutely instrumental, especially in Baltimore City. The work that's been done to assist with the opioid crisis in Baltimore City has been tremendous. From what I saw on Charles Street at your CCBHC, it's absolutely vital for us to continue to invest. So could you guys address that, please?
Sure, happy to. Appreciate the question. So one of the things that maybe will be helpful that we could do is send around, we did a mapping of the 9 core services that compose a CCBHC, and then we mapped it against the public behavioral health system and whether it is a service we do or do not reimburse for, whether it be through Medicaid or through other grant funding. So when I say that there's no disruption of services, Mr. Henson mentioned OMHCs, right? So we fund OMHCs through the public behavioral health system, as well as covering those that are uninsured that access services through an OMHC. So that is, when I say that there's no disruption of services, for many of these services that fall under the umbrella of the 9 core, there are other ways that organizations or providers are able to get reimbursed for these services. I think the other area, and I certainly will defer this to Mr. Henson and to Ms. Grainer here, is around the concern around the SAMHSA expansion money that is sunsetting, which has been used, at least in my understanding and through the planning grant activities that we've been doing, is to expand staffing or expand hours or data and reporting or EHR investments, those kinds of infrastructure investments. And so this is where the department would welcome to partner with the existing CCBHCs on submitting new applications when the funding announcement comes out. Because as I said, we have spoken with David DeBornay of SAMHSA, who said that they fully anticipate that additional expansion grantee dollars will become available. And I wanted to affirm and reaffirm with David that our existing CCBHC expansion grantees would be eligible for those dollars, and he did very much say that. And I will say the department, although we are in very, very lean fiscal times, and as one of my colleagues says, with unlimited resources, we can do unlimited things. We are trying to figure out, should there not be a pathway through federal funding, whether there is bridge funding that would support the organizations that would almost mirror the funding that they had received from SAMHSA. But again, that we're playing a little bit of budget Jenga right now, trying to understand for future years out. And it's my understanding that 3 of the 5, their funding sunsets on September 29th, and then the remaining 2 of 2026, my apologies. And then the other 2, their funding sunsets September 29th of 2027. So we've started to do some financial modeling of what would that bridge funding potentially look like. And, for lack of a better way of putting it, where do we rob Peter to pay Paul to make sure that if federal funding doesn't come through, we have the resources to support. But I certainly defer to them to talk to their operational impact.
Thank you, and thank you for the question. I'll keep my response very brief. I think if I refer back to my presentation, one thing that I said repeatedly is that care coordination is really the secret to making CCBHCs work. And we have achieved that 45% reduction in the use of ED services across the board because of that care coordination. That is not a service that is reimbursable under OMHC today. So it's those things that we do outside of the traditional structures of OMHCs that keep people healthy in communities that would go away if this funding ends. So again, if we look at those numbers and we think about that 45% that were diverted from EDs in each of your jurisdictions, that's the impact that would be if this funding goes away and there's no bridge to get to the next step. Those individuals would continue accessing care unnecessarily within the emergency departments or within the criminal justice system.
Thank you, Madam Chair. If I could just have one more bite at the apple. I appreciate you guys, especially the gap funding, the bridge funding. That sounds like sound solution, and I hope we continue on that path. As to the JCR, I know you guys have until May, and so I'll be waiting with bated breath. But is there a chance that you could give us at least a preview of some details on the cost-benefit analysis that you guys have done so far? Because I'm a little discouraged by the numbers that you guys have produced from other states. It seems like maybe it's, I don't know the breadth of the work that you guys have done, but it seems, the varied results seems limited. So is there a, preview you can give us on where your cost-benefit risk analysis is going for the report?
So thank you, Delegate, for the question. And I know that this is certainly something that I think we're all keenly interested in. What I would like to say is I'd like to take the question for the record and get back to you. I have a couple of ideas that are percolating, but want to make sure that I can run it by the team so that they don't yell at me when I get back that I promised on something that they can't deliver in a short turnaround time.
Thank you so very much, all of you, for all your work. Let's keep it up.
Thank you very much. And just a reminder to everyone, all of our speakers and our members, to make sure you're speaking into the microphone so that our folks on the other side of the live stream can hear it. I have Delegate Johnson.
Thank you, Madam Chair. Thank you for coming to answer the questions and doing the presentations. So I was looking back at your page 9 of your slides, and it said none of the current grantees currently provide all 9 core services to qualify as a certified CCBHC. However, each grantee attests to the federal government that they meet the CCBHC criteria. So what is the basis for you making the statement that they don't meet the standards? And offering 24/7 crisis service is a CCBHC required service. And I see on the same page 9, you say none provide the 24/7 service. So if you could speak to us a little bit about those two things, and will that endanger future grants?
Sure. Thank you, Delegate Johnson, for the question. So again, this was based off of information that we had directly gathered from our existing grantees, that none either as a sole entity, and again, this is certainly something that we can continue to discuss with our partners here at the table, as either a sole entity or has entered into what they call these designated collaborating organizations. So where you are contracting with other providers to be able to render that service and then qualify to meet the definition of providing those 9 core services. So Sheppard Pratt doesn't have to provide all 9 core services within their existing infrastructure. They could partner with somebody else to render that additional service. So again, that was based off of, and I'll certainly turn it over to CBH and Sheppard Pratt from their perspective, but that was our understanding based off of some mapping that we had done as part of these planning activities. And then for 24/7 crisis, yes, sir. That is a requirement as a core service, that 24/7 crisis services are a core component of delivering on the CCBHC model.
But you said collaboratively, but you said that none of them provide the 24/7 service.
That is our current understanding, that none of them currently provide 24/7 crisis services.
Okay, so my question was, would that jeopardize the future grants if we're not meeting the criteria?
Well, our goal here, right, is through the planning activities is to understand, and my apologies for not answering your question in full, is to understand where are there gaps in the service delivery model so that by the time we would apply for a demonstration grant, they would have demonstrated that they meet all 9 core service criteria and then therefore can be certified.
Thank you, Madam Chair.
Delegate Hill.
Thank you all for your presentation. I was a little confused. Some of this is, interestingly enough, really kind of new, the CCBHC and these grants, and I guess that's an appropriations thing. So I actually, once the second presentation was done, I understood the first presentation. So I'm sort of following up a little bit on what Delegate Johnson was asking about. I need to have an understanding, if you could help me, with these 5 clinics, or maybe it was 9, because I think Mosaic is actually owned by Sheppard Pratt, right? So
That's
it's,
right.
you know. Are you all filling a gap that we had where we had patients on Medicaid who could not get these services? Or are you trying to provide a better quality service? If you expand, are you trying to replace the other providers of these services? And as an example, this committee took a trip up 2 interims ago to Klein Family Center in Hartford County that seem to provide all the services that you're listing, but yet they're not counted as a CBHC. So as you expand, would you be, you know, again, would we take someone like Klein and say, we'd like you to become our next CBHC? Or are we creating new ones? I'm just not understanding how this fits into the total landscape, thank you, of behavioral health care for people on Medicaid.
So is that, I'm sorry, Delegate, is that directed at the state?
Whoever's
or-
best suited
Okay.
to answer the question. You explained the CCBHC, but I don't understand where you fit into the landscape.
So Marshall, do you want to talk about it from a provider's perspective, then I can talk about it from the state?
Thank you, and thank you for the question. I mean, if we think about OMHC services, clinic services that exist throughout the state, those services are providing access points to behavioral health, and those are important services. The distinction that's important here is that within CCBHCs, we are really looking at that high utilizer population, right? Those individuals that utilize a lot of behavioral health services, a lot of somatic care services. And so we're providing that more intensive level of care and treatment, that care coordination that's necessary to keep that population safe and well in the communities. So that's the gap that you're asking about. It doesn't supplant OMHC services. It certainly enhances it.
Besides the CCBH or entities that are providing this service? Or only the SAMHSA Grants in Maryland are doing it? And what percentage of the patients requiring behavioral health services are getting it with the ones we have? Who's not getting it? I mean, again, what's the fuller picture here?
Yeah. So that care coordination does not exist for that higher utilizer population, right? So that truly is the gap. I'll defer to Deputy Secretary Lord for the remainder of that question.
Sure. So Delegate Hill, when we think about different innovations in behavioral health, CCBHCs is one of those innovations. So as I said, the model was developed about a decade ago. It was designed off of being a corollary to federally qualified health centers, where can people enter one door and get a coordinated set of services. So in some ways, there's a lot of overlap with FQHC services, right? So FQHCs provide somatic care. CCBHCs, the goal is to provide somatic care. FQHCs provide behavioral health services. CCBHCs provide outpatient mental health services, right? But I think what we had found, and again, is that there's still an immense amount of stigma around accessing behavioral health services. And where do you go to get a coordinated set of care that is going to meet you where you're at? And so the federal government developed CCBHCs as a proof of concept to try and figure out how do you increase access to services, because again, behavioral health nationally, there's wide variation in terms of access, utilization, quality outcomes, and so on and so forth. So how are we innovating on this? So CCBHCs was one example. The Health Home Model, which is another program that we have here in the state of Maryland, which actually does provide intensive case management for clinically, behaviorally, and socially complex Marylanders. So we have targeted case management. So the state does have other types of programs that are meant to design, or that are designed to meet a wide array of service provision for Marylanders, depending upon the level of care that they might need. Most recently, CMS released an example which was called Innovations in Behavioral Health, right? So that was another model that took a look at, how are you coordinating a set of services, where I think we have historically struggled on the behavioral health side with evaluating some of these models, and I know Delegate Ruff had to leave, but it will be in some of our work that we're doing around the JCR, is what are the quality and outcomes of these services, right? So, and with the proposal that's been put forth around, starting with 2, it's a proof of concept. And this is where we're also learning from other states of what has worked well and what has not worked well with the establishment of CCBHCs. We took that approach also similarly with collaborative care, right? And so we want to make sure, and I think, where CCBHCs has struggled a little bit is how are they benchmarking this against those that are not receiving CCBHC services. Missouri, I think, is a good example of they've been at the pioneer of CCBHCs, and they are a population of about similar size to Maryland, of a little more than 6 million. And through demonstration year 5, which I think ran through 2022, they served about 160,000 Missourians. Right, so when we think about this from a cost per service versus cost per person, these are some of the other considerations that we're trying to take into account, as well as what was it like to receive that service? Were consumers happy? Have we established benchmarks for comparing our population who is receiving CCBHC services versus those who are not? Are we seeing the reductions in ED utilization? Is this targeting a specific population like adults versus where we see a gap in our service model as it pertains to children, for example? So I think these are some of the pieces that we are trying to pull together as part of our planning activities, as well as through the work with the JCR. And the department, we've laid out the behavioral health continuum of care, and we're happy to resurface that for everybody. I know it's been a minute, which sort of lays out what are the different services, the service array that Maryland is offering for behavioral health, as well as our white space analysis, which is where are there gaps in services? And so I think to your point, like, how does CCBHCs fill those gaps? I think those are things, because we already offer many of these services, we're trying to figure out what would be the right model for Maryland, but again, not disrupting what is already in place for the Marylanders that they're already serving.
Thank you, Madam Chair.
Sorry for the lengthy response.
No, I appreciate it. Having worked in this space for a number of years as the chair of the Public Health and Minority Health Disparities Subcommittee, which is now our good friend Delegate Hill, understanding this space is very complex. If I may, my understanding is that CCBHCs sort of serve that one-stop shop. We have the collaborative care model, which is that primary care setting where we can incorporate behavioral health all in one place. But CCBHCs are the one-stop shop for our high acuity behavioral health folks with comorbidities sometimes. But it is, again, a primary care setting for behavioral health, and also an access point because you can access a CBCHC regardless of your ability to pay, much like our FQHCs, which again is the somatic care with other services. This is centering behavioral health care, but also has other services. Isn't that so?
Yeah, I think that is a fair summation. What we are learning from some of the evidence that is coming out about CCBHCs is that they may not always be located in the communities that might have the greatest need. Some of the most recent data that is coming out is that CCBHCs are being placed in high-density areas where there are already a broad swath of services, and they are not necessarily being placed in areas with high levels of poverty. So when we're thinking about addressing the social determinants, and this has also been some of the challenges, which again, we're trying to unpack and figure out, what would that impact be for Maryland, with really thoughtful and intentional data analysis and those types of things. So, and we've not always seen that CCBHC services have been used by the high acuity populations. And so, because each state gets to design their CCBHC model in their own way, and they can have priority populations. But some of our most recent data is showing us that older adults, veterans, children are not necessarily the ones that are using CCBHCs, which may be good, bad, or indifferent, depending upon what the need of the state is. So I agree with you, Madam Chair, around the summation of it. I think we're just trying to figure out, based off of lessons learned, is the model being implemented in the way that it was intended, and then what would those potential implications be for Maryland?
Could I add one? Sure. May I add one thing, Madam Chair? I just want the one other key piece, and this is for FQHCs and CCBHCs, is the payment structure. So it is the prospective payment rate. So all of these services could be getting a fee-for-service Medicaid rate, or they could be paid, reimbursed by our managed care organizations. But the difference is that FQHCs get paid differently. And FQHCs, it's more money because you get paid if someone walks in your door and gets one service, you get sort of a flat fee for that individual. So CCBHC sort of operate in the same way. So that's when we're saying there won't be a disruption in services. We still pay for all of these services, but when we're talking about CCBHCs, we're talking about changing the payment structure to be a prospective payment rate that's more of like a flat bulk of money, no matter what happens, and that, you know, is intended to improve access and quality.
And thank you for that clarification. I think that's very helpful, especially it also makes it clear how it's complicated, because how do you compare, and especially in this space, a lot of services don't necessarily accept insurance. You know, they are private pay, so it's not exactly an apples to apples. Delegate Riley.
Thank you, Madam Chair. Actually, by the wonderful questions and both of the presentations of the panel, a lot of my questions have been answered. But I'll follow up after, listening to the Secretary. So one of my questions, I think from the CCBHCs. You had said, because I was going to ask, what is your biggest concern during this lap time? And I think what you said, just to clarify, was that the care coordinators are not currently paid, and you would like for them to be reimbursed. So I wanted to ask the department and the secretary, is that something that some of these other states that you're looking at, are they paying that particular workforce or not? And I guess also, it seems like there's a disconnect between the health department and, the folks that are using this program, or actually have the centers, and understanding exactly what they do. So if I could, Madam Chair, if you could answer the thing on, on the coordinators for other states, but I'd like for either Mr., what is it? One of the two. Sorry. Yeah, Mr. Henson or Ms. Granner to actually explain to me, do you think that the health department has a complete understanding and complete knowledge of actually what you do? And is there communication as they look at these other states to see that they are incorporating what you actually do going forward?
I can jump in on that last question first. I would say that the department has engaged more recently, certainly with the stakeholder group, to really be bringing in that perspective of what's happening on the ground. So there certainly is that collaboration. I will share candidly, there is variability to how CCBHCs are implemented. So it is complicated. And there is a need for more discovery, more education, more learning in that space between both the provider network as well as the department. So we need to keep those doors wide open and make sure that we're walking through this in tandem. So I think there's a lot of opportunity.
And then regarding your question about care coordination, we do reimburse for care coordination through different programs. And so what we can do is take that question back and get back to you with the various different ways that we currently are reimbursing for care coordination services. I mentioned two. So one is targeted case management and the other is health home, but we can provide more specifics.
Sure. All right, I'm just doing a quick time check that it is 4:23, and we are going to take our last question on this briefing. Delegate Tavares.
Thank you, Madam Chair. And thank you for the presentations. They were very insightful. My question is with regards to, in the line of, and in the spirit of Delegate Ruff, with regards to how are you interacting with the fentanyl cases and such, particularly with juveniles? My concern is that, yes, we're working to extend the number of beds for juvenile individuals with substance use disorders. My concern is most of them are male beds, but now the problem is expanding to female juvenile And all I'm hearing so far is, I'm not hearing. And so where are you working? Where are you with working with the treatment centers or trying to gain?
So, and I'll certainly turn this over to our CCBHC colleagues around the role that CCBHCs can play in connecting youth and family to services. For most of the services, and although I'll keep me honest here, colleagues, all CCBHC services are outpatient services, correct? Right, so there are no beds that would be reimbursed as part of this. They are all outpatient services. But SUD and treating for SUD is one of those components in which CCBHCs looks to link youth and families to services. I don't know if there's anything else that you want to add there.
And I think the only other thing that I would add there is for CCBHCs, children and youth are a big focus of it. For Shepherd Pratt specifically, we are embedded in schools across the state of Maryland. And a lot of that work that we do in schools is that early detection work. And so the goal is typically to get those individuals connected to a lifetime of service so that we're not needing to access those high acuity beds that you're referencing, right? So that CCBHC component is an important access point, an important front door for children and youth, but it is really intended to keep them out of those higher levels of care that you're referencing.
Thank you.
Thank you very much. Just a couple of things. Clearly, we are very, passionate about expanding our access to care. I understand that this is a deliberative process to understand, like, what is the best model? What gets us the best patient-centered care, addresses those social determinants of health, make sure that we're getting into the communities that need care, and also what is the model that allows us to access and draw down those federal dollars and really leverage state funds against the federal funds. So we look forward to hearing more about that. I want to thank you all for being here. I know it's been a couple of panels today, and you are free. You are not on our next briefing. We will be going down, and then we'll bring the live stream back. It is currently 4:27. This ends the briefing on CCBHC's Certified Community Behavioral Health Centers, and we will be starting our 3 o'clock briefing at 4:35. Thank you very much, everyone.